He travels all over the world. So without further ado, Dr. Kaiser.
Thank you.
You bet.
Thank you. It's good to be here. It's good to be in California. I was actually in New York yesterday and until this morning, and because of the way that the airlines work so well these days, I didn't get back quite when I expected to last night. So in any case, it's good to be here. Thank you for the opportunity to spend some time with you. I hope we have some slides, or we're really lost. Can you hear back there? Sorry to hear that. I want to spend the little bit of time I have this afternoon talking about integrating healthcare through health information exchange, but I intentionally entitled, and I'll come back to in a moment, want to remind us why we're here and why we're doing this, and it's really about integrating healthcare, and that was indeed, let's see, I have just like downtown maybe. There we go. So what I would like to do in the next little bit of time is basically two things. I want to provide you a bit of an update on some of the things that are happening in the California Health Equality, or CHEC program as it's come to be known. Some of the ongoing work, some of which was talked about last May when many of you were here, and then some things that are poised to be launched in the next month, next few weeks. And in doing that, I also want to provide a bit of a preview of some of the ways that we're hoping to use health information exchange to improve population health. And some of what I'm going to mention in this regard is in a very formative stage. We're still trying to work out how some of this may actually happen, but one of the opportunities that I think we have at the Institute for Population Health Improvement is because we're involved in a number of other activities. We manage the operations of the California Cancer Registry at the moment, and we're involved in a number of the activities of the Department of Healthcare Services related to healthcare reform. And one of our guiding principles, if you will, throughout is how do we bring these things together? Because really that's the potential promise of health information exchanges. How do we make healthcare better? And indeed, I want to start by just reminding us of the problem in a very distilled form of that we're trying to fix. And you know, quite simply, modern healthcare is one of the most information-intense and knowledge-based industries or activities that human beings have ever engaged in. Probably next to the intelligence community, it is at the top of the list. Yet we haven't brought our systems, our delivery of care systems and other ways of thinking about care quite to that level because of the explosion and the ongoing and escalating explosion of biomedical knowledge and technology, and the consequent increased specialization, subspecialization, super subspecialization of medical care practitioners. You know, information and the number of providers that touch a patient in for any given condition keeps increasing and increasing, to now that for many individuals it's not at all uncommon that they would have 30 or 35 different providers that they see over the course of the year providing some part of their care. And unfortunately, those providers aren't connected in any sort of predictable or consistent way. And there's all these silos of information that, if they were perhaps brought together, would actually result in a more effective, certainly a more cost-effective healthcare delivery system than what we have right now. And as the knowledge and the technology continues to increase, as the prevalence of chronic conditions increases, as it certainly is, in large part as a result of the increasing knowledge base, and we can treat things that formerly were not treatable and people simply would have died. We now can treat, and all this has just resulted in an increased complexity of care, and so what we're trying to do is to bring that together. I mean, the evidence is patently clear at this point that either from a quality of care perspective, from simply a service, delivery of care, or from the cost perspective, the current system is not sustainable. It's not giving us a reasonable return on investment for the large amount of money that is spent. So we have to do something about it. So that's kind of my editorial preface to the conversation. But I think it's important to continually remind ourselves what it's about, because there's a great tendency to focus on the technology and to focus on the gadgets and the gizmos and forget what it's all about. And in many ways, you know, what we're using today may well be replaced tomorrow or next week or next year. And so we continually have to think about what's the mission and what this is all about. So with that, let me come back a little closer to ground and talk about the California Health Equality Program. As Pam mentioned, we are the partner with her office and with the Health and Human Services agencies trying to increase the implementation and deployment of health information exchange in California using the funds provided by the federal government. And we're always happy to take federal funds and use them however we can. We have a pretty straightforward mission, and I think it's very consistent with what the agency has. We want to promote coordinated and integrated healthcare by catalyzing the implementation, deployment, uptake, whatever the word you want to use, of health information exchange. We have some more finite or perhaps more measurable strategic objectives as far as integrating care by getting health information to the people who need it when they need to make decisions, which in many cases is going to be the patient or the family, in addition to the caregivers. We want to not only spend all the money that has been provided, that indeed is one of the mandates that's driving this process, is to spend it in a relatively short period of time, but hopefully to spend it prudently and wisely and to get some real measurable impact on that. To do that, we have to create a trusted environment in which information exchange can occur. And as I said at the outset, we would hope to align what we're doing with other healthcare reform activities, piggyback them, integrate them, for, to use an overused word, but it's a word that we'll see a lot of going forward. Indeed, I would posit that over the next decade, probably the two driving forces for healthcare are going to be trying to find value, increase the value, which is quality divided by cost, and doing that by integrating care in all the different ways, whether it's clinical integration, economic integration, functional integration. I mean, we can look at integration in a number of different ways, and we certainly here hopefully are focused on clinical integration in particular. Unfortunately, some of the timelines for some of these other projects, like the dual eligibles that we had hoped to marry up, but because that implementation date has been pushed back, that's not going to fit the way we had hoped it would just 6-8 months ago. But there are others that we are hoping to build onto. This just gives you, again, a very quick overview of the health quality program. And I don't know whether I have a pointer here, but the amount of money that we started to play with was $16.6 million last September when it became official, and that has been allocated into a number of buckets, and I will talk a bit about most of those buckets going forward. But that provides some construct for how we have tried to allocate the dollars that we have. And our activities I think one way of kind of categorizing or looking at what we're doing can be things that might be considered national or having potential national import, those things that are more focused, or at least at the moment, on a statewide audience, and then those things which are geared more towards a regional or local or community-based intervention. And so I want to use that construct in part going forward. We will talk about these things, but under the national, well, you can read the list as well. So let me move to there, and I would say that most of these things that fall into this category of national or things that may have national import really focus on promoting standards and standards for how things will be done. We have to take a fairly broad or inclusive view of standards when we talk about HIE. It's in many cases we're talking about policies and procedures which sometimes aren't as typically thought about as a standard. It's not a number or a perhaps as finite as often. In this regard, as far as the creating a trust environment, again, our focus is how do we create that environment in which all the different stakeholders or participants feel comfortable and confident that the information that is being shared, whether it's being shared between or among organizations, or whether it's being shared between political jurisdictions, such as across states or across counties, is indeed going to be protected and handled the way it should. I think one way of looking at this is what might be called the 4 No's with a K. How do we know that the conversation is secure and protected health information is indeed protected and being maintained securely and confidentially? How do we know that we're actually talking to who we hope to talk to and who we would like to talk to? How do we know that we are talking about the right person? And then, some people have the same first and last name. How do we make sure that we indeed are talking about the right person with that same first and last name, or whatever may be the case? And how do we know that we actually have the individuals or person's permission to have that conversation? And so those are the, if you will, the 4 No's of a trust environment. And I'm not going to talk about this in great depth because there will be more about it tomorrow. If I recall correctly, there's a whole session about this tomorrow where a lot of this and other things will be talked about. But the problem in some ways is that, despite sharing and increasing sharing within communities, sometimes we create stovepipes there as well. They may be just a little bit larger stovepipes, but it's much the same. And there's obviously this practical problem that if you're going to do those 4 No's, do you have to have all these point-to-point agreements, and which becomes a matter that's simply not workable. So we have to find a better solution. That solution currently goes under the title of trust communities. And I have to confess that I continue to struggle with some of this terminology. It's a terminology that has developed relatively unique or specific to HIE that's not used more broadly in healthcare. And I would even go so far as to say is that it may be a bit of a barrier to getting the larger healthcare community to embrace what's going on in health information exchange because they don't understand what we're talking about often. And so as we move forward, I do think we're going to have to move the language that we use that has grown up with a set of individuals kind of understanding what they were talking about and having a particular thing in mind. But when we get beyond this, not only to the healthcare community, but to the larger community, people just don't get the words, and so we're going to have to find a way of talking about things in a way that everyone gets it, and that we don't have to teach every person that we talk to, what are the four no's in a trust environment, what are all this that we have to talk about. So that's one of the, I think, underlying challenges and things that we're going to have to struggle with. Going forward, there has been a considerable amount of work done here, particularly with the Western States Consortium, and as I suspect many of you know, the first trust community, if you will, launched in November between California and Oregon. The Office of the National Coordinator is now promoting this idea as perhaps the preferred method for interorganizational trust to occur. California just participated in a national standard-setting conference in this regard, and will be pilot testing some things going forward. And again, more will be, you'll hear more about this, and there'll be more conversation tomorrow, so I will leave it at that right now. A second way of approaching this is, or part of this is in the provider directory. So again, the problem is, how do we know how provider X, doctor X, nurse practitioner X, communicates with his or her network of other providers, and how do we ensure that that person is indeed the person that we want to talk to? And again, the solution that we're using, or the words that we're using, is to create provider directories. We have, as with health information exchange in general in California, have taken a federated approach to it. I go back to Washington a lot and have conversations with a lot of people there, and they often say, well, why don't you do it like Vermont does it, or why don't you do it like Indiana or Tennessee, or just have a statewide exchange. What is all this stuff that you guys are doing out there? And those are usually for people who have never gone west of the Rockies and don't understand California. When I tell them things like, well, in the Los Angeles Public School District, there's 135 languages recognized, they kind of, maybe it's not the same as Vermont. So in any case, we're moving forward in this regard. We are planning for a pilot program for inter-health information organization exchange this summer. And for those of you, again, who may not have heard this, the Western States Consortium, that hasn't been in our lexicon very long, but long enough that people have started to recognize it. They're changing their name to the National Association for Trusted Exchange. And you can say you heard it here first, but I wouldn't be surprised if NATE, or the National Association for Trusted Exchange, changes its name after some period of time as well. But that's a conversation for another time. Two other things perhaps worth mentioning here. The HIE Ready, hopefully most people here not only are familiar with it, but have had the opportunity to utilize it. That is using the existing meaningful use standards to promote transparency and to facilitate purchasing and other decisions. And we think that among other things, will certainly have a salutary effect in reducing the need for interfaces and other costs and complexities that may be associated. And perhaps just going forward, again, using this schematic, the problem, we recognize that Meaningful Use 1 doesn't promote the standards for all the interoperability requirements that are in Stage 2 Meaningful Use. It's going to be very expensive to custom develop those interfaces, and so again, the HIE Ready is putting forth set of interface capabilities that are standards-based, and hopefully will provide information that will allow potential users to do side-by-side, apples-to-apples type comparisons of products. This was first put forward in November. Currently, there are 13 participating entities in the HIE Ready. That number will increase. We have made no attempt to publish this, at least more than in single copy form, in hard copy because it's changing rapidly, so it is basically maintained in an electronic version. We do understand that there are a number of other states interested in participating. And so we expect this is something that will grow as we go forward as well. And this, if you've not had a chance to, this is just a page of what it, if you access it, it looks like, you know, the vendors, the different capabilities, and you can just go down and compare line by line what they have according to a scheme and a rating scale that's relatively easy. Granted, is somewhat subjective and judgmental, but it seems to work pretty well. For what's doing there. The other entity that was on that list, the LOINC mapping system. LOINC has again, this is one of these things where these words come up with these acronyms, but for the hardcore, LOINC stands for the Logical Observation Identifiers, names and codes, and it is a database and a universal standard for identifying medical laboratory observations. The providers must receive, and for meaningful use 2, they need to receive and incorporate lab results using the LOINC terminology. However, relatively few laboratories are currently in a position where they can actually do this. The LOINC Mapping Assistant Program is targeted to some high-volume independent and hospital labs to use the LOINC terminology, and hopefully this will facilitate the effort. We're very appreciative of the efforts of the California Healthcare Foundation, and we'll expect to be recruiting some of the first laboratories to participate this imminently in the next month or so. Shifting gears, some of the statewide activities that are underway, and I want to focus on 2 in particular and give passing mention to the third. The Immunization Gateway Service is in progress. It is not quite there, but it is well on its way. Inspire is a program that I want to take a few minutes to talk about, because it gives you kind of a preview of how we're thinking going forward, not only in addressing public health issues, but the, I think, incredibly important matter of HIE sustainability, and whether there is, in essence, a business case or something that HIE can do that will make it sustainable going forward. And you don't have to read the news very far, at least the HIE news very far, to know that a lot of HIE programs that were in business a few months ago are not, or soon will not be, in large part because they don't have a sustainable business model. And so we have spent a fair amount of effort thinking about this and have some thoughts going forward. The having trouble with the clicker up here. The Immunization Gateway, again, the problem is that this is a requirement for stage 1 or 2 meaningful use, but California, like most states, lacks the capacity to meet the demand for information, and so providers are often having to submit requests for waivers for this because there isn't the infrastructure that will support their meaningful use applications. The Immunization Gateway that was funded not long ago, does automate portions of the registration using an online portal. It does streamline the process and helps facilitate getting the information to the and getting things set for the California Immunization Registry as it is maturing. Again, this in and of itself is an evolving and maturing entity. I think we have at this point a pretty strong collaboration between the Department of Public Health, the 7 regional registries and Health and Human Services, as well as the vendor. Their testing is ongoing right now in putting this in place in the CDPH IT environment. Pilot submissions should start any day, very soon, and hopefully all providers will be able to start submitting by mid-June or thereabouts. And this is just for those who like schematics, which kind of gives you a picture of how it will work. All the community HIOs and the other EHRs, hospitals submitting to the gateway, which will then farm the information out to the regional registries. I would say that the top part of that may well evolve in the months ahead to look somewhat different than it looks right now, but Lynette is shaking her head saying, don't say any more. But again, all of this is in many ways an evolving concept. So Project Inspire, another acronym, and this one stands for Interoperability to Support Practice Improvement, Disease Registries, and Care Coordination. And we weren't very good custodians of the acronym process because we didn't use all the letters, and we kind of doubled up on some, but it made a word that hopefully resonates a little bit, although I should say there were a couple predecessors to this that didn't resonate so well, so this is an ongoing process. But the intent here is how do we improve the acquisition and exchange of information for what would be considered high-impact conditions? High-impact conditions being things like cancer, Alzheimer's disease, diabetes, stroke. There are a number of things that would fall in this category, and certainly as healthcare reform moves forward, as we have an increasing focus on population health management, there is going to be more and more disease registries, not only maintained by providers and health systems, but also maintained by the state. I'm not sure the state fully understands that yet, but we will of necessity have a number of additional registries for these chronic conditions. Cancer has, in the California Cancer Registry has been a showcase example of what a registry can do for many years now. We need to now increase that to include things like stroke and Alzheimer's and some other conditions. And Inspire basically is focused, there are 2 initiatives that are embedded in one, but they relate to each other. The first is what might be packaged under next generation registries. And the second is what at the moment we are calling health information homes, or the health information home. And let me say just a little bit about each of those. The problem with the current registries are that they're manual, or largely manual, which requires a lot of effort to abstract the relevant information, and it's effort all the way up the chain from starting at the local hospital or other provider that's submitting it to the regional registries to the state, where that information has to be abstracted from the charts, manually abstracted. It has to be cleansed and purified, and all the things that data has to go through before it actually comes and takes up permanent residence in the state registry. And currently for the cancer registry, that's taking 2 to 3 years to get done, which greatly undermines the usability and the utility of the data, and certainly makes it essentially of no use for clinical care. with the advent of electronic health records and the increasing prevalence of that, we believe there's a great opportunity to take the information directly from the EHR and with a few intermediate electronic steps go to the state registry, which would make it available in close to real time. Now, the problem is, of course, that how the data is collected in those electronic health records is not the same and all over the board, and has, one of the reasons why it takes so long when you do it manually is because when it's inputted into the records, I wouldn't say it's a mess, but it is. And it takes a lot of work to clean up. And there's a couple of potential solutions to that. One of which is using structured data acquisition, which is the approach that we're taking. Another would be using natural language processing or something else that you could search the information you need, and it would then prepackage it. And there are some emerging tools that makes that interesting and potentially feasible, but it's not quite soup yet in that regard, and it's not something where we feel we can go down that pathway quite yet, although, again, there are some promising developments in that regard. So we're looking at it from how do we use structured data capture and then transfer that, collate it, and transfer it up to the registry. To operationalize this somewhat nebulous concept, we are starting with the Athena project, which are the several UC medical centers, and it focuses on breast cancer. So we're using a specific high-impact condition where we would hope to get the breast or the information from the point of care from the clinicians through the Athena, send it up through the chain, and populate the registry. Now, sounds straightforward, and some would say, well, you punch a few keys and it happens, but it's not quite that easy. But over the next several months, we hope to operationalize that using some of the ASCO clinical oncology data exchange standards, and provide an evidentiary base for why this makes sense to do on a broader scale. At the moment, we're focusing basically on a single network, if you can consider the UC hospitals a network, but a single source and a single condition. But where that has to move to is multiple sources, multiple conditions, and you don't do that without starting small, piloting, figuring out what works, what doesn't work, and moving forward. But we believe that if we can demonstrate how to do it in this setting, we may well be able to progress relatively rapidly. Probably the biggest challenge has nothing to do with technology, but it has to do with medical care, healthcare culture, and getting structured data, and how do we actually get that, and how do we get doctors to start thinking about structured data and using structured data sets and those sorts of things. So it becomes much more of a sociologic problem than a technologic problem, and we expect that, well, it's typically the case in most of these healthcare reform activities. Is much more sociologic than it is technologic. In many cases, the technology is pretty straightforward. The other concept or idea I'd like to leave you with here is something that we are calling the Health Information Home. Again, it's had a couple of other names, but this is the one that we're using right now, where it's conceptually much the same. But again, the problem is individuals with high-impact conditions receive care from lots of different providers across time and space. No one has the full information. Results in all kinds of inefficiencies, waste, quality, safety problems. And the opportunity is can we create a home that actually would facilitate more accountable care that would also help with the disease registries, but may also help providers, whether they be health systems or hospitals or even medical groups or whatever the provider unit is, to do population health management. because this is an absolute requisite going forward. Every provider is going to have to be able to manage their population of patients by condition, by other ways that you might slice or look at populations. And there are a limited number of vendors who are actually out marketing things in this regard. But the question is, does everyone have to recreate this wheel to do it going forward? And does every provider have to develop their own solution or purchase their own solution to do their population health management? And the concept or the idea that we're exploring is whether the health information exchange and this pathway that we're proceeding down with regard to the public health registries, could we have if we think of it as a home, another room, not a closet, but another room that could do population health management, and it basically would be in many ways a repository for the information that the providers could access and do their population health management. We think there are probably some major economies and efficiency if we did it this way. It is potentially something that would create a sustainable revenue flow that might solve 2 or 3 problems at the same time, which of course is when you're trying to fix things, you always want to find the most parsimonious solution. So evolving concept. I expect you'll be hearing considerably more about it as we move forward. The last item that I at least would like to mention in this regard is the open library for HIE projects, and again, this is perhaps our way of trying to salvage some of the work products that have come out of the ARA investment, whether these be model contracts, best practices, software. There's a plethora of different work products. How can we put these in a way that they could be harvested or utilized by a larger number of people as we go forward? And moving forward, the regional community health information investments, or how we're supporting local. I don't think I need to say a lot about this because there's been a fair amount of attention. The acceleration award program, again, how do we accelerate the adoption using the ONC funds as the universal elixir that's going to catalyze events. And we have designed some award programs and that really are focused on building the infrastructure and expanding the services at the local level. Again, you've heard about these. Some of the perhaps factoids worth noting that nearly $6 million have been invested in the state so far. About half of that has been done in the last several months under the CHECK program. We're currently administering 17 different awards in this regard for 13 different organizations. And in several different programs. So there's a lot going on in this area. And we would posit that we're probably up to a penetration of nearly 40% of California's population falls in the areas that are covered by these. Now, not everyone is benefiting at this point, but it is a notable figure that progress is moving forward. This just shows a map. Again, I don't have a pointer here, but of where the HIE Acceleration Awards are. Those are the dark blue areas. To make it a little more complicated, this shows a number of additional awards, the rural awards, the analytics, and some others have been made. I just got the sign here that I need to speed up, so that's why I'm... But the area that we need to particularly focus on going forward are those light blue areas where there isn't much activity going on at the moment. And as you no doubt recognize when you look at those light blue areas, those are mostly rural parts of the state. There aren't a lot of big population centers there, which gives way to the Rural HIE Incentive Program, and I understand there was a well-attended workshop immediately prior to this, so I'm not going to repeat probably much of what was said there, but we are hoping to build on the capacity that already exists with some HIE providers to, again, catalyze or increase the footprint of HIE in these areas, which are always going to struggle and are always going to have difficulty just because they are rural and don't have many of the critical mass of assets often that are needed to move forward in this regard. And again, I think that's been covered probably well enough earlier. There are 5 different providers that are offering these services. I think there's also going to be more said about this tomorrow in addition to the workshop. So in the interest of time, I will move forward. If I can make the technology work. The last thing I just want to mention in passing, because I think it is will be seminal. It's again one of the ways that we feel we're trying to cross-fertilize different healthcare reform efforts, and this is our Blue Button initiative for Medi-Cal. As you probably know, the Department of Healthcare Services is moving forward to get essentially all of Medi-Cal into managed care programs. Now, all has to be put in quotes. It's probably 90, maybe 95% or so. Although, having in a much earlier lifetime kind of launched a lot of Medi-Cal managed care in the 1980s when I was health director. It's kind of amazing to see where we are today at approaching or imminently approaching 95% penetrance in this population. But the idea of the Blue Button initiative, and I'm going to take it as a given that everyone has either heard of or knows something about the Blue Button, the National Blue Button initiative that's underway of providing patients access to their information, is that we want to implement this in Medi-Cal. If we do, this will be the first Medicaid program in the country that will be utilizing this technology, so this is putting California clearly on the cutting edge. We would hope to do this in 2 managed care plans. Whether we can find 2 that are ready and up to it remains to be seen, but at a minimum will be 1, but we're hoping for 2, and hopefully that will then catalyze others, and that this will start something that will take on a life of its own, as the Blue Button has in some other venues. So with that, I will stop. Thank you for the opportunity to be here. If there is time, I will be happy to take any questions or not take them, if that's a better part of valor. Or we can move on. I think there's a break. Is it? Okay. Thank you very much.